Evening, everyone. Mike Selby here with Michael Galgano and the Virtual Global Spine Conference team. I'm just getting a few people filtering in at the moment. It's evening in the US. We've got midnight in Switzerland with Alexander, who's here with us. And it's morning in Australia and Asia. So got a few different time zones in as always. We welcome questions. I put a case up that I was going to discuss on Twitter and LinkedIn last night. A few people have fired back answers, so that's always good. I'm going to just roam through this case, and it's not a really complex case, but I think it just brings up a lot of points about adult scoliosis and the kind of work we're doing and how things can go wrong. So we'll get people to weigh in, get people to give their opinion as we go. I'm just going to load presentation here. Alrighty, so talking today very briefly about a case, but my general philosophy is in scoliosis, there are many ways to fail, not just one. And this is one of those ways. You just think you're getting it all right. You think you know what you're doing, and these things happen. So this is not my primary case, but I think I may have actually even come in and assisted for a little bit on this surgery done by one of my more senior colleagues here a number of years ago. So lead off, this is 2013, 65-year-old lady. She does have some well-controlled psoriatic arthritis, otherwise a really fit patient, skinny, non-smoker, bone mineral density normal for age. So she comes in with a VAS, back pain, 8 out of 10, poorly controlled with medication. She gets some radiculopathy from the apex of that curve. She reported probably having a curve as a teenager that wasn't treated. And to me, this is a kind of typical old idiopathic scoliosis pattern rather than a degenerative scoliosis pattern, but there can be a lot of overlap between the two. I don't know, do you have any way of differentiating these, Alexander? Get you on.
No, it's hard. Do you have any X-rays from her youth when she was 20 years old? Some patients store them in a shelf. Do you have a sense of progress in the last decades?
No, she didn't keep any of them. We went back a bit, but we couldn't. I mean, I had films going back to about 2008 on her, but she'd always had a scoliosis then, so it wasn't back that 40-year period to really know if it was there beforehand. But I mean, to me, this is that pattern that the idiopathic thoracolumbar curves get with age, where they kind of hyperlordose their lower two segments, and then they get a little kyphotic almost through the TL junction. And that kyphosis can be a different apex from where the apex of the curve is. So it can always be a little tricky when looking at it. She also here is quite negative when you look at her plumb line. And I know that full spine radiograph has been taken with her arms out, so not in the perfect position, and she may be leaning back a bit as a result of that. But her SVA is about 3 centimeters negative there. So that's something interesting as well. Kind of goes against it being a degenerative scoliosis pattern. Generally, those patients are more kyphotic throughout the lumbar spine compared to this. So I'll roll on. These are all her tests. And this is back 2013. And I think they decided on proceeding with surgery on the basis of these investigations. So I'll pick on my co-host today, Michael. It's going to say, Michael, this kind of curve here, L5S1 is not too bad. L45 has some minor facet degeneration. Apex of the curve is L1, L2, L3. Would you consider here going short, or do you always go long? What do you want to do for this kind of case?
Well, first of all, just to answer your question that you posed to Alex before, I think it's an interesting question about how you could tell if this is AIS, that's basically morphed into the adult variant, or if this is degenerative scoliosis. And I think one thing that Larry Lanke has talked about is to look at the pedicle morphology, right? If you have really hypoplastic pedicles, that probably tells you that this was once an adolescent case, which is now ADIS as opposed to degen scoli. So were you able to look at that to tell if what the pedicles look like here?
Yeah, so her apical pedicles on the concave side at 1 and 2 are really small.
Yeah, so to your point, this is probably ADIS then as opposed to degen scoli. You know, I did a case like this about 4 or 5 months ago. It looked strikingly similar to this. The sagittal balance wasn't quite as negative, but it was fairly similar though. And I actually took a short segment approach to it. I did not end up taking this down to the pelvis because just like in this case, 4-5 looked good. 5-1 was completely pristine. And I basically just did something, I think from about T8 down to about L4. And I had a fairly good correction with that. And just looking at this superficially, I think that's what I would be considering in something like this too.
I think that's pretty fair. I think a lot of people would take that approach. And look, I think after discussion with the patient, that was the approach taken here. And surgery was performed through a regular posterior approach for this one. But I suppose I've put up here, you know, levels are always something that we debate and argue about. But I mean, a posterior short open from here, and I'll just flick back, is probably T9, T10 to L3. You know, you could, because it could go to L4 as well. So there are a few different options. You know, would you go long T9 to pelvis, MIS, lateral, hybrid, open anterior? Big, you know, we were talking briefly before off the conference about some of the English approaches, and look, some of the surgeons would, particularly in the UK, may advocate doing this anteriorly, and then there are a bunch of other different options as well. But I think yeah, I think the 3-4 disc here, when I go back a slide, sorry, is probably degenerate enough to include it and tilted enough. So I think you're probably committed to going to 4, as Mike was saying. And I'll show you what was done. This was what was done. These are the first erect X-ray post-op. You can see all the bone graft there. I think that was just a mixture of locally taken graft and bone chips. So fairly good coronal plane correction. I think you'd agree with that. It's a good result, fusing to L4. So this is her sagittal profile though, and you know, she still is that little bit further back. And unfortunately, my colleague that did this didn't really do many full spine X-rays post-op. So that's the best I've got. I don't have a full balanced film. We moved on, and she was followed up, and in 2014, so the film that's showing there, she was doing okay. She'd had a little bit of low back pain, but overall doing fine. And the implants showed no evidence of cutout, no major loosening, no problems at that point. I think you can probably gain from that X-ray though that she's still a bit negative there. And in 2016, she started to develop a lot more pain. So now we're seeing something that's a bit more concerning. That's basically a form here of what I consider distal junctional kyphosis. And I felt this was being driven a bit, unfortunately, by her overall negative balance. It's kind of the body's attempt to put her back where she belongs. I'll pick on Alexander again. Alexander, what do you think? 2016, you're 3 years down the line, you've got this X-ray.
Yeah, I think we can see these more and more often. I don't know how negative is the SVA. Was it like
2 centimeters? So she's basically as she was before surgery.
Yeah, and I think in the end we always feel smarter. I have my own experience with the short segment fusion in these patients, and I'm always unlucky. I don't know, I wasn't so aggressive in 2014. So this was, I was in another hospital, and all my patients were revised by my colleagues. But I think it changed a little bit. I don't know whether you have had the same philosophy in 2014 as you have now, or whether these 7 or 8 years experience changed your mind. But I think we see these too often. And the patients get older, 68, 70, and in the end, they don't expect to get into a revision surgery after 2 or 3 years. They all want a longer benefit of a surgery. So I think now it's clear we have to go to the pelvis. but I guess it's not possible without a whole spine.
Yeah,
we have to
I
look
will show
whether
you in a moment. I agree. And look, I did things completely differently in 13 and 14 to what I do now. You know, it's been a real evolution, and I've made so many mistakes on adult degenerative scoliosis that, you know, if I counted them on my hands and feet, I wouldn't, you know, I need more limbs. But I, I am, you know, constantly trying to learn from these cases. And I just think, you know, this is not that complex. As you suggest, the solution here is going down to the pelvis. And this is in 2018. She sort of battled on, didn't really want anything else done. But she developed this really severe DS and stenosis at 4.5 on a level, if you go back, it was pretty much pristine, and now she's starting to fail at 5.1 as well. Anyway, again, I think, you know, the patient and perhaps the primary surgeon were a little resistant to suggesting further options. And so off she went to a pain physician and got this, which was probably never going to help. It was a $20,000 battery and 2 wires for peripheral neuromodulation. So,
Mike, may I ask you, when I was in the AO spine courses 10 years ago, John Webb was there. And John Webb from Nottingham told me, don't make all the mistakes I've done too. Go big, go to never stop at L1, all these sentences. It was 10 years ago. I guess you heard this philosophy 10 or 12 years ago. Do we all have to go through this evolution, or can we just stop with short segment and make a long segment from the start? Or do you have always to discuss with your patient what is he willing to undergo?
So I suppose for me, this is where I don't know, and the answer to every case. And this is where machine learning and AI, predictive analytics, I think is going to be so helpful going in the future. It's going to have a big database of cases with these comorbidities, with this degree of degeneration at 4.5, 5.1. And it means that as surgeons doing this work, we have to really document these cases. We have to put all this data in and then see what comes out at the end so we can learn from these experiences. So that, you know, ideally back in, you know, well, let's say 2013, let's say 2023, this patient comes along, same case, we can say, okay, we fuse you to L4. We know that 70% of patients will make it 5 years with that construct, but 30% will need revision. We fuse you to the pelvis. We know that 90% of patients will make it 5 years with that construct, but 20% will get hip OA and need a hip arthroplasty. You know, and then they probably need a dual mobility cut, right? So I think that's where data collection, analytics, machine learning, and AI is going to be so important in helping us advise patients going into the future. Because people like John Webb don't know, right? I don't know how they're all going to go. It's really challenging. So these were her long films when she came to me in 2019, and you can see here she's still negative, although she's compensating now by sort of tilting through the thoracic spine. She has a PI of around 50. And you can see that DS with that disc erosion at 4.5 in particular, but recognizing 5.1's also going. This is a CT which showed descent of the sort of construct. The construct's solid, but the construct had kind of eroded into the adjacent pars and facet joint, almost disconnecting it on one side. Quite significant pathology that probably was never going to be covered with that peripheral neuromodulation device. And bone scan just showing severe degeneration there on the SPECT CT. So she'd actually seen a few surgeons by the time she got to me. And, you know, there were various things proposed to her from people with various understandings of spine and biomechanics, but decompression alone was raised as an option. Posterior revision just going down to the pelvis. Posterior revision encompassing that thoracic spine and the pelvis, 360, so using anterior or lateral cages, T9 pelvis only, or 360 upper thoracic to pelvis. Michael, my friend, what would you do?
Well, I think you've got to take her down to the pelvis, I think, at this point. And as far as how high up you go, I think you've got to take her past the apex of her thoracic kyphosis. You definitely need to recontour that rod, because I'm worried about PJK, just the way that looks at some point, because that rod is kind of jetting out posteriorly there. And I think the big question is, is she having any claudicatory symptoms or radiculopathic symptoms? Like, does she need to be decompressed too? It looks like she does based on the MRI. Correct?
Yeah, she definitely had claudicant symptoms. So,
right. Yeah, so she's definitely going to need to be decompressed at the 4-5 level. I think the big question is, if you're leaving all the dorsal bone intact at 5-1, do you need to get a cage in at 5-1? We always like to say secure the base, do A lift, do a T lift there. But, to access that via posterior approach, you're going to be drilling away a fair amount of bone to get a cage in there. So is it really necessary in this case to do a cage at 5-1 if all of your posterior elements osseously are completely intact? So I would definitely go to the pelvis. I'd probably take her up another level or two past that thoracic kyphosis, and then definitely recontour that rod.
Yeah. And look, I think what doesn't appear as well on this imaging is that probably the screws are just on the end plate there at the cranial level, but that also she probably got about 3 to 4 levels of quite severe disc degeneration there through that mid-thoracic region, which wasn't really there on her imaging prior to her initial surgery. So she's just wearing everything out. And the other issue I've got here is the location of these screws and sort of really eroding into the pars there. So I think it's kind of a bit of an unstable situation, and you've got to basically get all those screws up a bit higher and be able to recontour the rod going into the pelvis. So anyway, this is what I did. This is her first stage. I did a staged a week apart. I still believe in A-lift at the base, and I know that's controversial. We talk about that all the time at this meeting, but she had really good vascular anatomy. I just went in a double level A-lift. I took the PLL at both levels, particularly 4-5. And then I got a scan, and I got a CT scan because I really wanted to see what her balance was now, and whether that was acceptable. And that CT actually nicely shows that kind of mid to approaching upper thoracic degeneration she was getting as well, which actually made me go a little higher than what I was planning. So that's where I think the staging helped me a little bit. Her screws were actually all pretty solid. I just resighted them. And then this is a long O-arm stitch film that I got after the posterior instrumentation with an additional SIJ fusion device. And look, I was quite happy with her balance on table. And I think the long films on table, however you get them, just is so valuable in these cases where a patient clearly, had the best attempt the first time and ended up out of balance. So we've got to get it right when we do it the next time. So this was my ultimate solution for her. I've seen her for over a year follow-up. That's her now. She's balanced back to where she should be, age-appropriate SVA. Next, doing okay. She's a little kyphotic in that mid-cervical area, so I'm watching that. That's pre-existing. And I think her parameters are fairly nicely restored. She's a happy patient, so that's a good thing at the moment. But she was happy for the first 2 years or so after her previous operation, so I'll keep you updated. Would anyone have any objections to what I've done? Please feel free. Fire away on the chat and let me know. I'll have a look and see. But
Mike, I think it looks awesome. I guess the question I have is about doing your bilateral SI joint fusions along with your S2AI screw. So are you seeing in your practice, and you've been in practice for a number of years, a lot longer than I have, are you seeing a lot of your pelvic screws loosen up over time? Is that why you started doing this now?
It is. And it's because I suppose I haven't had a huge number loosen to a point where they're symptomatic. I've probably revised 3 from between 5 and 8 years ago in the past year or so. So it's not a huge volume, but it's enough that I've just become more comfortable doing this bedrock technique. And it's really like after the first couple of times you've done it, it probably adds 10 minutes total to the procedure, particularly if you use navigation. So to me, 10 minutes now to save an operation down the track, I think it's worthwhile. But I know not everyone feels that way. And hopefully a bit more data is going to come out. I understand David Polly's doing a big multi-center randomized trial in the US on this. So hopefully we're going to have an answer in a year or two.
Hey, Mike, this is a beautiful image compared to 2014 before the first surgery. It's really big difference. May I ask you 2 questions about the cervical spine? Did the patient have any cervical issues? Was not looking very lordotic, the C-spine?
So she definitely does have disc collapse and some focal kyphosis through there, but she's got no cord compression and she gets no symptoms from her foraminal stenosis. So we've let that ride at present. But she did have a full spine MRI before I revised her.
And can you just explain the right L5 screw, how you connected this?
Oh yeah, it's purely because of the line of her previous screws and her the angle I needed to get a decent screw with a decent channel in 5. I could have resighted it with a straighter, shorter screw after I went for the rod, but again with the when I've got some sort of secure fixation there in the front, I'm very happy to use little trans connectors. I don't think they weaken the construct too much, and I prefer to keep the rod straight and not overbend it and weaken it. So yeah, I'll throw those little trans connectors in just to match up to my rod, particularly L5 and L4. Not a bad kit to have in the little bag of tricks there.
Do you sometimes consider to go to the iliac crest to do like a kickstand connection? For me, 100%. It's easier. I don't want to miss is the screw. The more screws down there, the better it is.
Yeah. No, I think the iliac kickstand is very good, but she wasn't coronally imbalanced at all. And so I didn't do that for this case, but I would strongly consider it. That's a CT at a year. She's pretty solid at 4.5, 5.1. And that's her upper thoracic construct. Just for a bit more detail, I did a 2-level vertebroplasty and 2-level subliminar band to do my best to prevent PJK. We're at a year now, so hopefully I've got over that first 6-month risk, and the next risk will be about 5 years' time. We'll keep an eye on her. So awesome. Yeah, got a few comments in the chat box, but I think what people would do, I think Mike's got some cases now. I'll start having a look at the chat box, and we'll go down and get some people in on the next cases. Is that all right?
Sounds good, Mike. All right, so we'll change up the flavor a little bit for the first case, and let's see. All right, so this first case is a guy I took care of about 6 or 7 months ago. He's a 23-year-old, and he's got a history of NF1 and shunted hydrocephalus, and he presented to us with a vague low back pain for about a half a year, but more importantly, he had about 2 weeks of inability to really ambulate. He had a left foot drop, and he also had progressive neurogenic bowel and bladder. So here's the MRI scan that we had. I'm not sure who's on here. Is Rasuli on here? You want to take a jab at this, Jonathan? No? All right. What do you guys think? Alex, what do you think if this guy walks into your clinic, 23-year-old with progressive neurogenic bowel and bladder and leg weakness?
So within 6 months, I have got a neurosurgeon as a colleague.
This is all extradural though, Alex. This is all you, buddy.
So it's a cystic tumor from L2 to the posterior elements, or from the posterior elements to L2. It's for Wendy Gibbs, it will be a second to identify this tumor. It looks like a primary bone tumor. The patient has got neurofibromatosis.
Yeah, type 1.
Type 1, yes. So within 2 weeks, the symptoms came up.
Yeah, he had vague back pain for about a half a year, but he started having really progressive neurological decline over about 2 weeks or so. And here's the CAT scan that we had here. So I agree. I mean, it's obviously it's a primary bone tumor. And, one of our hunches was he's got NF1, he's got neurofibromas everywhere throughout his body. So this has to be some bizarre looking neurofibroma, right? So we had it biopsied, and actually came back as an aneurysmal bone cyst. So we had it biopsied via ultrasound because this came up almost to the surface of his skin. So, I guess the big questions are, how do we go about taking this out? Do we need to address the component that's in that vertebral body? And do we need to fuse this guy? Right. If you look at his CT scan, it looks like that he's got 2 pedicles involved. He's got facets involved above, below, and he's got his pars, obviously, is pretty disrupted. So really the tumor is kind of holding things together. And this grew pretty rapidly over the course of about 5 years, because we actually, for one reason or another, actually had an MRI on him from a couple of years ago, and this was not there. So whatever this was grew over the course of about 4 or 5 years or so. So what do you guys think about level selection here, whether or not you would fuse or not? And how would you go about doing this?
Michael, can we just take a step back? If this is an ABC, what's your experience with denosumab and like medical treatment, at least as an adjunct with this?
So I've never used it for ABCs before. I know it's routinely used for giant cell tumors, but in this case, when someone has a pretty significant or precipitous neurological decline, I wouldn't feel very comfortable waiting on it. I think if it was smaller, didn't have this degree of equina compression, you could certainly get our medical oncology colleagues involved and see what their thoughts about. But I'm not sure how much literature there is about ABCs in denosumab. For giant cell, there definitely is.
Yeah, I think there's a little bit, but yeah, it's not as well clarified. I've seen Stefano Boriani talking about it previously a couple of years back.
Right. And then you could also use sclerotherapy for these as well. I know for some of the smaller ones, again, not with neurological decline. I wish Wendy was on here to get some insight from her about her experience with that in ABCs, but there definitely is literature to support that though. So what do you guys think about level selection here? Would you guys do a multi-level fusion? Would you even fuse at all? Or would you just take this out and just do a laminectomy basically?
I mean, to me, it's going to be a pretty destructive excision of that to get all the way around it. You're taking a lot of pedicle, complete facet joints. I would at least stabilize it. I don't know if it's completely going to fuse. Initially, you'd have to watch it, but I mean, it's unlike me, but I would probably do this all from the back. And but then, I think your friend here for monitoring is the newer carbon fiber type screws and implants, because
right.
It doesn't look like, I mean, you could get an erect x-ray, but it doesn't look like it's going to be grossly unstable. It's going to be a deformity. And so you can go with your carbon fiber implants, maybe level up, level down, and then you can monitor it.
Yeah, you called it, man. That's exactly what I did here. So we did get pre-op embo on him as well, because as you guys know, these are like ticking time bombs. These are very, very hypervascular. So we had it emboed beforehand, and I'll show you a quick, like a 90-second video or so, but just to orient you, because this is really what the vantage point is. This is caudal rostral. Here's our T12 SP, and here's our L1, and this is the L2 nerve root. So I'll show you guys a quick video of how we went about doing that. I brought in the microscope from the get-go with this case, because what I didn't want to do is throw our cautery into the tumor. And just like Mike Selby said, we decided to use carbon fiber fixation here. This was kind of an unusual approach in that we had to do a lot of soft tissue meticulous dissection here, a lot of muscle splitting just to get through this. So we finally find the capsule of the ABC, and then we basically got an aqua mantis. We cauterized the heck out of it. And then we performed the inferior L1 lami, superior L3 lami. And then you could see here that we find some of the virgin dura here, and you could really appreciate how stuck this tumor is to the dura. I don't know how we did not get a CSF leak this case, but we didn't. And we use a lot of blunt dissection. And once we got around the posterior part, we basically just, sectioned some normal muscle here. And then there was another component of the tumor you could see that was actually within the psoas muscle, and we took that out. Now, the only part that we didn't go after super aggressively was the part in the vertebral body. We basically drilled it out, but we decided against doing a corpectomy on him because this was an aneurysmal bone cyst and not like a chordoma or a chondrosarcoma. And to be frankly honest, in a case like this, it's very, very difficult to get a complete en bloc resection, right? When it's completely stuck to the dura like that, you're not going to be getting negative margins. And for ABC, you don't necessarily have to. So the carbon fiber screws I thought were money for this case. They are finicky to put in there. I think there's still a lot of refinement that has to, go about as far as getting them a little bit more user friendly. But the post-op MRI scan is very easy to follow. And you can see we had a pretty nice GTR here. Here's a tumor. It was massive. It was almost about 10 centimeters in maximum width here. And I think it's important to keep in mind too, that we, to preserve that top SP and that bottom SP like we did here. Because if you take this out, in my anecdotal opinion, you can accelerate the degenerative disease at the adjacent segments of the UIV and LIV +1. So we really tried very, very hard to just kind of undercut those spinous processes as opposed to just lopping everything out, including those superior and inferior ligaments here. And I think we had a pretty good result there. And all of this, in case you're wondering, this is just all embolic. This is all onyx, actually, embolic material. So cool case. and he's doing well. He had really nice neurological recovery afterwards. Any of you guys have any questions or comments about that case?
Michael, Matthew Berchuk on the chat, he said he'd go a little longer, which I don't think is a crazy idea at all either. But we were just discussing about getting a fusion in this kind of setting, right? You know, embolization, really wide excision. You know, using allograft biologics. What are you doing? Matthew said he's using both.
Yeah, I basically just use some allograft. Use cortical cancellous chips. And, we were diligent about really exposing the TPs as widely as we could. The thing is, even if we did a longer fusion, though, the place he's going to pseudo is going to be right in the middle, right? So I think that's kind of the issue here. So he has really good bone. He's a young guy. I really wanted to see if we could try to spare him, going all the way down to L4 if we could help it. So as of now, he's about half a year out of surgery. He's doing fine. His upright films have looked completely fine. But I don't think it's unreasonable to go longer. I just, for his age, I wanted to see if we could do a little bit shorter. I don't know if he's ever really going to arthrodese, to be honest with you. I don't know. I just hope that his hardware stays intact long enough. All right, the second case, a little bit more orthocentric here for you guys. This was I actually ran this case by Selby. This is a 14-year-old female. So Mike will be happy to see what I did here. So 14-year-old female, and she was about a year and a half post-menarche. She was a Rissa grade 4 at the age of 14, and she presented to us at the age of 12, actually, with the skin on the right. She had a fairly moderate double curve here, and we decided to brace her. She didn't really like the brace. She was just kind of non-compliant with it, and unfortunately, this was during the heart of the pandemic a year and a half or so ago, and we kind of lost her to follow-up. There was a lot of appointments that were canceled due to weather and whatnot, and just not being able to get access. So she came back to me about 2 years later with the skin on the left here, and the curve had pretty substantially increased. And she's having a lot of kind of vague back discomfort, cosmetic issues. Just not very happy with the overall appearance here. And obviously, she's only 14; she's still growing. We can appreciate on these upright sagittal x-rays that she really has no thoracic kyphosis as well. And these are her bending films. And we can see both of these curves are relatively flexible. They both bend out to less than 25 degrees here. And again, here's her x-ray. So what do you guys think here? What would you guys do as far as treatment options? There's a whole slew of treatment options, from observation to tether plus fusion. What do you guys think here?
Mike, will you take it over? You're doing a lot of more AIS.
Yeah, I mean, there are so many treatment options for this, observation and bracing. And Alfredo is on the chat. Our friend is saying maybe not the best case to brace. And look, I mean, I think with what she started with, I don't think bracing is unreasonable. I think you're now in a position where if you're going to tether her, you've got to do both curves. If you're going to fuse her, you probably have to do both curves. I've seen this case, so I don't want to bias what is done. I think from a technical perspective, she would be a candidate for a more mature double row tether. But again, you're going to have to do both curves to do that. And that is still sitting in that sort of, borderline experimental category if she hasn't got a lot of growth left. And it's never my primary recommendation for these curves, but some patients, for various reasons, family experience with scoliosis surgery, desire to do high-level gymnastics, these sort of things do really want to consider that option. And so, I suppose a tether here, I'd have to do double row tether and thoracic and lumbar. And that probably would quote it up to 1/3 at least reoperation rate, if not more, and a higher tether breakage rate. Not all tether breakages mean reoperation, but yeah. So sometimes the more reliable thing is to go fusion, and there's a heap of different options there. But yeah, Alex, I mean, Mike knows the key to this, and I'm not gonna crap on too much more. Just get Alex in.
No, thank you. I mean, you've got a ton of experience, so it's always great to hear your insights with this. And we talked to her about all the options. about, non-fusion surgeries versus, versus doing selective thoracic fusion. I guess my issue with doing a selective thoracic fusion here is that really the ratio of the thoracic to lumbar here. And then that lumbar really did, that curve really did increase pretty substantially from the time she was 12. So another big question is, do you stop at L3 or L4 in these cases? And I think Mike's got a lot of good evidence from his early years of practice that patients you stop at L4 at, they definitely have significantly higher increased rates of adjacent segment degeneration down the road, right? So that's one of the issues of why maybe we would consider stopping at L3, not get a perfect result as opposed to L4. If you stop at L3 though, then there's always that risk of adding on, right? Especially if they have significant wedging between those lower two levels, or if there's significant rotation, like what this young lady had as well. So a couple of key things when you are inserting pedicles. Now, I know it may be frowned upon that I got a CAT scan on this 14-year-old girl before surgery, but I don't navigate usually. I typically freehand, so I do like to get a preoperative CAT scan just so I can kind of get the lay of the land as to what all the pedicles look like, measure them all out, have everything measured out beforehand, figure out what's sclerotic, what's not, how big the pedicles are, because a lot of these patients will have type C pedicles. Some actually will have type D pedicles, and it's just kind of nice to know that going into these cases. And there's really two main ways you could cannulate, right? You could do transpedicular or you could do juxtapedicular. A lot of these end up being juxtapedicular screws like this. I think biomechanically they're probably a little bit weaker, but on the upside of them, you could get a fatter screw in, you could get a longer screw in as well because you can medialize it a little bit more. Now, these are definitely the most challenging screws to place, are these medial concave pedicles. And I think Dr. Lenke did a great job really outlining these type 3 pedicles. These type 3 spinal cords really are at a 28 times greater chance of having neuromonitoring signal changes because that cord is really effaced up against that medial pedicle wall here. So I'll show you guys what I did. Before I show you what I did, this is a quick cartoon video as to really the quick steps as to how you do this. This really just shows a differential rod contouring where we lock the top and bottom here. This is the Medtronic system that I used. We rotate the rod into the sagittal alignment. We place our reducers in here. We take them out of corona curvature, bring them into thoracic kyphosis, and then you could really fine tune things with segmental or en bloc derotation afterwards. And this is a quick two-minute video or so showing you guys how we did this. So after we do all of our subperiosteal dissection, I like to use these diamond drills here. I think it gets a very nice, precise, pilot hole into the pedicle here. And then we basically freehand all of our lumbar screws first. Now, I'm not sure, what do you guys do? Do you guys, Mike and Alex, do you guys stimulate your screws typically, or do you not?
I do lumbar, but I haven't found value in doing thoracic.
Yeah. Right.
But I cheat now. I used to be like you and use all freehand, perhaps a lot less fluoro than even what Lenke described. And then, but now I use all 7D navigation for this, so I cheat.
Gotcha. Okay.
So
no, it's not cheating. I think early on in your practice, like me, you want to get your confidence up. You want to make sure that you could do these the traditional way. And honestly, I didn't train with navigation, so I'm very comfortable freehanding these. Now, these are some very hard pedicles to place, right? These concave hypoplastic pedicles. These are the ones that maybe you could dilate up a little bit. These are also the ones that I typically use a K-wire for, because if you are freehanding them, on occasion you'll get a lateral breach. Like I think I did it at a handful of these, and this is where the K-wire comes in handy to make sure that you've got a nice, a nice bony bridge between your breach and your good pilot hole there, and then the K-wire comes in handy. Now, as far as my levels I selected for osteotomies, I basically do inferior facetectomies at every level, and then I do a complete Ponti osteotomy from L1 down to L4, completely take the facets out, and basically cut across the pars. Now, this is a great device here. This is not the Masonics. This is actually the Sonopet, and believe it or not, this is the tool that we use to take brain tumors out all the time in neurosurgery. But you could put a blade tip on it, and it acts just like a Masonic, but it's actually lower profile. So this is what I use. You get a lot of nice autograft from it, and it's a very precise bony cut, and it doesn't bleed at all. So after we do all of our osteotomies, we basically do our differential rod contouring here. Now, in her case, because she's got a double curve, we have to make sure that you incorporate some lumbar lordosis into this, not just hyperthoracic kyphosis here. So once we rotate that rod into the desired sagittal plane alignment, we will not lock the top and bottom screws, but we basically just tighten them pretty significantly so that the rod doesn't rotate on us. And then we could put our different open and closed clip reducers on here, just like what you see here. And we started off with the concavity of the thoracic spine. And now you can see how far apart the apex of that rod is relative to the spine. And then again, we just do one more final rod rotation maneuver, lock it into place, make sure it's in the proper sagittal alignment. And then we start getting all of our reducers down. And then we bring the spine up to the rod at that point. And then we do the same thing on the contralateral side. And then after you do that, it's all about fine tuning, right? You put your derotators on. We got some unblocked derotation in the lumbar spine. We did a little bit of segmental derotation in the thoracic spine. And after we did that, a little bit more fine tuning with just some compression distraction. We compress across the convexities, distracted across the concavities. And then this really just kind of fine tunes things at the end of the case. And I think we had a pretty good result here. Now, I ended up taking her down to L4, and I'll kind of go into a little bit why I did that as opposed to L3. And this is what her post-op x-rays look like. The reason I went to L4 as opposed to L3, and I talked to the patient and her mom and dad about this, was that she, I thought she had pretty significant wedging between 3 and 4. And I really didn't want to stop in the apex of her curve because she's still growing. And the other issue is that on the table, L4 looked really, really rotated as well. And when we looked at it in situ as well, grossly, it just looked very rotated. And I was a little bit concerned that we would end up adding on for her in the next year or so. So I did end up taking her down to L4. I think we probably could have gotten away with L3. But either way, I think we had a fairly good result after this. So why don't you go ahead and critique me, Selby? What do you think?
Well, look, I think here you've restored some lumbar lordosis above that, which is very good. And look, I think a lot of the judgments that we make on stopping at L4 may be related to older implants, although I have seen it happen with modern pedicle screw constructs. But I think, attempting to get that balance a little better may well be protective on those discs. And I think, sometimes you have no choice. And if she's still super rotated on the table, it's really hard to say, I'm going to stop at L3. Look, a couple of my my colleagues will do kind of stage surgery for this, where there's that borderline between 3 and 4, and they'll actually go in and cut the discs at the 2, 3, 3, 4. At 1, 2, 2, 3 disc space, and then try to see if that anterior approach improves mobility. I'm not sure if it does compared to a wide ponte at the back. This is a good result. I don't think you can complain about this. You just got to hope the patient doesn't do risky things for their discs in the future, like smoking and stacking on weight, and they look after themselves. That's right. But it's a really good result, man.
Awesome. Well, yeah, I asked a lot of very seasoned surgeons around the country. I wouldn't say a lot. I probably asked about 4 or 5. I asked Ali, I talked to Mike Selby about it. And it's amazing how many different opinions you get from this. I got everything from, double tethers to selective thoracic fusion to take her down to L4, stop at L2. It's incredible. But I think at the end of the day, I think we had a fairly reasonable result. So I appreciate your feedback, Selby. It was very helpful talking to you before the surgery.
No problems.
All right.
May I ask you?
Yeah.
Let me ask you, do you have to inform your patients about the tethering option? Is this already such a established therapy that you have to inform them? In Switzerland, we are very conservative, and Michael, this X-ray looks very nice, and you will get an applause from any Swiss Scoliosis center because we do it this open way still. MIS or tethering, is this standard? Do you have to offer this?
Look, not everyone offers all of these surgeries. I know in Europe, they do a lot more anterior for, maybe for like type 5 and type 6 lanky curves. That's not something that I was trained in. I don't do a ton of anterior scoliosis surgery, to be honest with you. I was trained to do mostly posterior. So I don't know if you're completely obligated to give them every single, option out there, every single approach, I should say. But I think it's reasonable to go over that, observation is an option, right? Bracing is an option, and we tried and failed those. Non-fusion surgery is an option, and I did talk to her and her parents about that. And then we talked about, selective thoracic fusion, the fact that she might crankshaft later on because she's still growing, and then whether or not we stop at L3 or L4. So I went over all of those things with them. So I do think that you should, if you're going to take these cases on, I think that you need to have at least some of the concepts down about some other surgeries that maybe you're not super comfortable with, that if they say, okay, I want to be an elite D1 athlete one day, maybe I should get the patient to the right person that maybe has done, 1,000 vertebral body tethers before, or something like that. So I do think that it is obligatory to have at least a bit of a conversation about that. All right, so it looks like we have a little bit more time. I'll go through another case with you guys. This was a 71-year-old female. Now, this is going to look like a very neurosurgical case, but there's definitely some interesting alignment issues I want to bring up with you guys. It's a 71-year-old female who morbidly obese and presented with left hemiparesis and left hemi anesthesia. And for the sake of time, I'll just kind of go over this. This looks like a meningioma. Okay, it looks like it's got a bit of a dural tail, and you can see on the axial cut, there's really severe spinal cord compression here. So I decided to take her for surgery, that we were going to do multi-level laminectomy on her, take out the tumor. And then a big question is whether you want to do laminoplasty, just laminectomy, or lami plus fusion in her. And this is what her upright x-rays look like. So when I was in neurosurgical school, we never got upright x-rays on a patient with an intradural tumor before. But I think it's really important to do that because of these patients, as they age, they develop this high increased T1 slope here. So she's got beautiful cervical lordosis, but that's really only to be commensurate with her high T1 slope that she has here. So when we positioned her for surgery, we took her and she's about close to 300 pounds, morbidly obese patient. We started losing signals. So our pre-flips showed that she had decreased left MEPs compared to the right. But when we positioned her, we basically lost everything on the left side, started losing things on the right side. So what would you guys do for this, Alex? Let's say that this was a degen case that you had with bad OPLL, and you position them, they're not really a good candidate for an anterior surgery, and you position them, you keep them pretty neutral, and you start losing your signals. So besides all the, check the neuromonitoring leads, blood pressure, steroids, what have you, what would you do in that situation? Would you wake them up? What would you do?
So usually this happens. We try to simulate the prone position with the awake patient. We ask them, lay down, do you feel something? But I would just go for continuous surgery. If you wake her up and with the next scenario, you will run into the same situation. You're the same point, unlucky. I think I learned a lot from the neuromonitoring teachers of mine, and they said you have to do this, and I would go on and complete the surgery plan you've had in mind.
Yeah, I agree. I went over this case with my residents a few weeks ago, and I asked them the same questions, and a lot of people said, flip anterior, flip supine, wake the patient up, but you're still going to have the same outcome, right? Once you flip them prone again. And this is not a patient that you're going to do a corpectomy on, a 3-level corp on, to take an intradural tumor. That's just not practical. So what we decided to do is we kind of played with her head a little bit, and we kept her in a not really the most ergonomically comfortable position to operate in, but you can't really appreciate it here either, but we flexed it pretty significantly, believe it or not, and we started getting our signals back. So at that point, wasn't back to baseline, but we thought we could safely take her. So here's a quick 90-second video, and I'll go into why I fused her after as well. And we did our 3-level laminectomy, basically from C3 down to C6. We took the interspinal ligaments from 2 down to 6. And I also took some of the facet too, because you could see how anterior this is. It's almost like trying to take out a disc from a posterior approach, right? Like an intradural disc. But instead, this is a big meningioma. So we did our durotomy very laterally here. This is almost, kind of at the same latitude line as the facet joint here. So what you can see here is that we're doing our arachnoid dissection. We cut our dentate ligament. We did this at the C4 level. We also did it at the C5 level. And we also had to rotate the bed really to get ventral access to it. So we rotated the bed, and then we rotated the spinal cord by clipping the dentates to the dura. And when I take these out, I try to take them out on block if I can. I hate using these, ultrasonic aspirators, because I think, it starts bleeding and then you could miss tumor. So what I do is I just like to bipolar these basically. I cauterize these. It emulsifies the tumor, dehydrates the tumor, and then it makes it a lot more manageable. And it basically decreases the overall volume, in my opinion, of these tumors, probably by about 1/3 or even 2/3 sometimes. You could see, we haven't cut into the tumor at all, but it's decreased pretty significantly. So once we had a resection here, you could angle the scope, make sure you don't miss anything. We ended up leaving about a 3 millimeter piece behind on that contralateral side. I think it's inconsequential at the end of the day, but I think we had a fairly good result. And then before we put our rods in, we got her back into neutral position here. And despite all of those screws being there, you can see we're still able to see this on the MRI scan. So I guess one of the big questions is, should I have fused her? And I'm not sure how you guys feel about that. I took her from C2 down to C6. And what do you guys think? Would you guys have done a laminoplasty here, maybe just a 3-level lammy, see how she does, or would you have been aggressive up front like I was with this?
Michael, I would have done exactly what you've done here, except I would have left it to someone of your skills to deliberately go into the dura like that. So no, that's just an awesome case. I had some great neurosurgical colleagues here, and when I diagnose intradural pathology, if I got time, I try to go on a system on it, because I do like looking inside there in a controlled fashion, and that was beautiful, mate. So yeah. Only thing I'll say, look, I was a big fan of C2 laminar screws, and I've actually published a paper on using C7 laminar screws as well. I'm seeing a few patients, that operated on years ago come back and they're a little loose. And so I've moved away a bit from them. I'll still use them as an adjunct in a big, long construct, but I've gone away from finishing on them if I can. And I know that's not possible in every patient, but it's just something I've been learning with time.
Yeah, I go back and forth, to be honest with you. I'm a big fan of the pedicle screws, but if I have a resident that says, I've never done any translaminar screws, I'm like, all right, let's throw some translaminar screws. And I'm not a big fan of it for deformities, but for a case like this where things are going to remain relatively static, there's not, huge biomechanical forces. We haven't done any osteotomies, corpectomy, what have you. I do think it's probably okay to to end with these. I could usually get pretty big fat screws in depending on the size of their lamina. I've actually gotten as big as like 5.532s in, believe it or not, and a fairly big guy before in C2. So either way, this brings up a good, a good topic about whether or not we should fuse these patients. So I like to look at the T1 slope and how much cervical lordosis they have. I know these are relatively new topics that really been borne out by Chris Ames from UCSF over the last few years. And I think, as we all know, the T1 slope is akin to the pelvic incidence. So the larger the pelvic incidence, the more lumbar lordosis. Same thing goes for T1. If you have a high T1 slope, you need a commensurate amount of cervical lordosis. So this is a case that I was referred a few years ago, where one of my colleagues had this patient come in. He felt she was myelopathic, so he did a 3-level laminoplasty on her, and he did not get upright X-rays, but you could see she had had a pre-op CTA for another reason. And you can see her T1 slope, even in the supine position, is about 50 degrees. Normal is about less than 30. And there's probably some age-adjusted parameter that really hasn't been kind of borne out yet in the literature. And this is what she looked like after surgery. So this is her first post-op upright X-ray scan. This is at about 4 weeks after surgery. This is at about 3 months. And then this is almost a year later, a little bit after a year, when she was referred to me for this deformity. So now she's got a chin on chest deformity. And we got dynamic films on her, and you can see she really has no extension reserve. And this is her upright scoli films. They actually cut her head off because she was so kyphotic here. She's got this upper thoracic kyphosis, and now she has a cervical kyphosis as well. And this is what we had to do for her. We had to take her for a multi-level ACDF, big posterior all the way down to, I think, like her lower thoracic to get her corrected. It was pretty incredible, what carnage can be done if you don't pay close attention to these parameters before surgery. So going back to my case, the reason I fused her is that this patient had a high T1 slope, 50 degrees. And, I think something else you have to take into consideration, and Chris Shaffrey actually talked about it on Virtual Spine a few months ago, is that some of these patients have what's called fatty infiltration of their extensor muscle. So a lot of these patients, as they age, they don't really have robust extensor musculature. And you have to be very careful about this, because as you strip away their facet joints, like I did in this case to some extent on the left side, you take their interspinal ligaments away, supraspinous ligament away, all of the posterior elements at a few levels, you take away all of their compensation for that high T1 slope that they have. And I think it's a lot easier to fix these up front with a fusion than it is to take them back like that last patient and end up doing some wacky front back, C2 to T8 or T10 or something like that. And like you can see here, despite all of these screws here, there's really no significant artifact within the spinal canal here. So what do you guys think about all those concepts? Is that a bunch of rubbish, or is there something to be said about that?
Michael, I think it's a nice case, but I will just throw it out there. You know, there are some that would say anytime you're stopping at C6, maybe consider going to T1. Don't know what you think about that and what Alexander thinks about it. I've actually seen some European papers on the rate of distal junctional failure in degenerative cases, so not tumor trauma, degen cases, being relatively high, stopping at 6 or 7. And whether once we've made that decision, do you just go straight to the pedicle at T1?
You know, the times that I've seen that, Mike, has been when the surgeon is not diligent about keeping that distal LIV+1 interspinous and supraspinous ligament intact. I don't necessarily think, at least anecdotally, that stopping at C6 inherently will make you have distal junctional failure. In the cases I've had in my own practice or that I've revised, it's almost always because the surgeon will place their last screw at the last level of their laminectomy. And if you've done a complete laminectomy at that last level of your last screw, that means you've completely stripped away that intervening ligamentous complex between your LIV and LIV+1. I think that's what puts you at risk of DJK, not necessarily whether you stop at 6 or 7. That's just my anecdotal opinion on it. Alex, what do you think?
Yes, I agree with all you've said, and I support Mike's command not to stop at C6. Well, I come from a Magal school, and massa lateralis screws are very easy compared to the C7 pedicle screws. And so whenever I was a young attending, my teacher told me, don't try the difficult screw in C7, go to T1 or to T2. This is at least better because you're crossing the junction. And he had such a good outcome with going to T1 and T2. And so I copied him without good evidence, but it was really his experience. And I have good results. I have less kyphotic problems below C6 because I go to T1 and T2. And the functional deficit is really minor. The patients are not unlucky because of the loss of motion in C6, 7, 7, 1. The opposite is the upper cervical C1, 2. These patients are unhappy because of the loss of motion. And so I would always give the same advice I received from my teachers, not to make it as short as possible. And Michael, your case looks so beautiful. And the fusion solution is always a safe solution. And crossing the cervical thoracic junction would be an option. It looks good here in this X-ray. I want to see the X-ray in 5 years, but I think you've done an amazing job.
Awesome. Well, I think that's about all the time we have, guys. I have a couple more cases, but we only have about 2 minutes left, or 1 minute left now. So thank all of you guys for joining, Mike and Alex. It was a pleasure as always. Awesome cases, great discussions. I'm not really sure what we have up for next week. Any of you guys know off the top of your heads?
It'll be up on Twitter and LinkedIn. That's what we'll say.
All right, fair enough. All right, guys. Well, have a great rest of the night or a great morning, and we'll see you next Thursday.
Thank you, Michael. That was brilliant.
Awesome, guys.